Welcome to the Health Catalyst podcast, brought to you by YPO. Here we talk about the business of health innovation, and I sit down with industry leaders who have been in the trenches. My goal is to share the lessons and provide practical and actionable advice to help you launch, grow, and scale your business. I am your host, Rodrigo Hute. Hello, everyone, and welcome to the podcast. Today, my guest is Matt Fusan. Matt is the SVP of Product and Strategy at Azara Healthcare. And in today's episode, we'll be talking about how to make value-based care a reality. In other words, how to operationalize value-based care with data and analytics. Matt, thank you so much for being here and welcome to the podcast.
Thank you, Rodrigo. Really appreciate it. Looking forward to our conversation.
Excellent. I'm looking forward to this as well. So let's start with the basics. If you can share a little bit about Azara Healthcare, that would be great. What is Azara Healthcare?
Sure. So Azara Healthcare started in 2011, and the two gentlemen that started it are actually still running the company today. So we've had really great continuity throughout the life of the journey. So they started out the business focusing on providing population health solutions to FQHCs, or federally qualified health centers, in underserved markets. Since then, I joined the company 4 years ago. We have expanded into two additional lines of business: payer or health plan business. We do a lot of data with it, exchanging with them on behalf of our clients, as well as commercial business. So anything outside of the safety net world. And we really focus on serving networks. So anybody in an ACO, a SIN, an IDN, whatever terms you want to use for a network, our software is really set up to handle network level clients.
Thank you. Are you across the U.S.?
We are.
Yep. So across the U.S.
We have clients in 44 states, I think, at the moment. Continues to grow. And that spans the spectrum from anything between fairly qualified health centers, their organizations at Roll Up, which is a primary care organization, commercial ACOs, payers. So pretty much across Alaska and Hawaii included. Actually, even Puerto Rico, a client in Puerto Rico. So we have some territories covered also.
All right. Okay. Good. So one of the key questions that I wanted to ask you is, like, I think a lot of, there is a lot of discussion around value-based care and, transitioning from fee for service to value-based care. And I want to ask, like, what are some of the biggest challenges that healthcare companies, face when they are transitioning to a value-based care? What are some of the top challenges that you guys see?
Yeah, and I think it really varies depending on organization type. So if we kind of think of it as a provider organization, so standalone, not part of a health system, their challenges tend to be different than a health system. So for instance, a lot of times it's resources and operational sophistication, right? They just don't have the people, the infrastructure, the workflows set up to really do value-based care in a successful way, including care management, care coordination. So for them, it really is ramping up their capabilities from a resourcing, infrastructure, technology capability standpoint. You take a health system, for instance, with ambulatory and acute, rarely is it a resource constraint for them. It's more of organizational challenges, right? Somewhat opposing forces. So if I have acute, which is going to really make money on inpatients and ED, yet I'm in a value-based care model, which says keep people out of inpatient and ED. Well, if I'm running the health system and I'm running both sides of that, it gets really challenging, right? So organizational direction and decisions on the health system side get really interesting. Once you get past that, then they just have so much data and so many different systems. You got to pull all that together to really get to value. So that's another challenge at the health system side. From a or really an industry-wide perspective, I see two major challenges that are really hurting everybody. One is, we all know about it, data interoperability, right? It still isn't there. I don't know that any government program in the near future is going to change that for us, right? They've tried many times. It really comes down to the organizations have to take it upon themselves. So we work with a lot of our clients that are on the provider side and on the health plan side, and we facilitate the exchanging of that data. What data is valuable? How do we do it? People are going to have to do that on a one-by-one basis, unfortunately, because system-wide interoperability isn't going to happen in time to really support value-based care now. And the other part is, because you don't have that, data exchange is a component of it, but because our system is so fractured and you may get care from many different types of organizations within a year, there's no longitudinal care coordination. Just doesn't happen. And it's clearly proven that longitudinal care coordination makes a huge difference in health outcomes and expense. Yet it's very, very hard to pull off with our data challenges and just the structure of our healthcare organization. So lots of things to pick from, but they vary a little bit depending on where you sit in the market or the industry, really.
Yeah, makes sense. The different kind of challenges, for sure.
Yeah.
Let me ask you a very basic question about value-based care, because everybody uses that term loosely and in different ways. But how do you define value in value-based care? So, and I would imagine that it's similar to what you were saying. I think it might mean different things to different constituents,
right,
different
right.
organizations. Maybe you can give us an example. I don't know. One
is, how do you define for your organization what value-based care is? To your point, right? It's nebulous. So what we did is to really simplify it and work with our clients and said, all right, anything that has payments over and above straight fee for service is in a value-based care bucket for our clients. You have to take some additional action or pay attention to something that will result in more money for you. That's different than fee for service. That's value-based. A lot of people define it in a tighter boundary, right? But we don't, especially with our federally qualified health center businesses. They're a little bit further behind the curve on value-based care. Ultimately, for value-based care, my opinion is the value is based on the contract, right? This is not nebulous. This is not something like, well, Rodrigo thinks the value is X, but Matt thinks the value is Y. The value is right in the contract. Here's exactly what it is. Now, how does that reconcile with patient outcomes, right? Hopefully that's in the contract, so you're balancing things. It's not all financial driven. But at the end of the day, the value is in the contract for value-based care, I feel strongly about.
Right. And now, there might be a case where there is a contract specifically focused on cost reduction.
Absolutely. Yep.
Okay.
Yep. And usually cost reductions in there, admissions, readmissions, reducing those rates are in there. Again, keeping people out of those acute settings is a major driver of cost, clearly. But yeah, and then how you align your really patient goals, patient outcomes, your clinical care, how does that determine into your value equation? Again, it's going to be organization by organization, right? I think that's the key with value-based care is it is so particular to organization, even though the model may be the same. As we know, if you've seen one healthcare provider, you've seen one healthcare provider, right? That's part of our challenge is there's just so much differentiation across the board. So I think it really is what does value in this contract mean to you, the organization that's in it?
Okay, so it's not one generic thing. It's on a case-by-case basis.
That would be too easy. We can't do that. That's healthcare.
Yeah. So the other question that I have is value-based care a payment model, or is it a philosophy on how to care for patients?
Definitely a payment model, but people do confuse it with philosophy, and I think that's a dangerous part, right? Value-based care is based off a contract that has terms in it that say you will do X, Y, and Z, and if you do X, Y, and Z, you will get paid X, Y, and Z, or you will get fined 1, 2, and 3, right? At the end of the day, value-based care comes down to a contract that has financial metrics and has targets for clinical improvement, et cetera. So it's not a philosophy, and I don't think it should be a philosophy. And I think that's where people struggle at times is we have a for-profit healthcare system, but at times people don't want to talk about the money side of it because it feels dirty or whatever. I only want to talk about the clinical side of it.
Right.
But if you run a for-profit health system, the money part of it matters a lot, or you won't provide any care, right? Yeah. So philosophy should be different than your contract terms, in my opinion.
Yeah, yeah. I've come across Sarah's framework for value-based care success, and if I recall correctly, you guys talk about like 6 key elements of implementing value-based care in a good way. You have a very nice framework describing that, and we might not have time to go through every single detail of the framework, but could you walk us through a little bit and explain this framework to all of us, please?
Yeah. This is something I've kind of been thinking of and working on for a while now. I've been really into this space for the past 10 years. And when you see the proliferation of different value-based care programs and models and contracts, you start to realize, hey, there's no way I can perform to just what's in this contract, then look at the next one, silo. So for instance, a number of years ago, had a client that had 16 value-based care contracts and 52 metrics across those contracts. Impossible to try to perform against 52 metrics, right? So then we started saying, well, what really drives success, regardless of the model? What is the underlying portions that will drive success? Because those metrics are going to change. Those models are going to change, right? CMS changes them literally every year. So if you're trying to set up your organization to perform against a specific model, you're going to struggle because most likely you're going to see changes there. And by the way, like our other client, it's 16 different models they were in. So the concept was, what are the underlying elements that are going to drive success? And then that way, you have an organization that not only can perform today successfully, but is built for the future. And who knows what models come out in 3 years from now. Hey, I'm okay and I'm ready to handle that model because I've looked at these different things and we've done really well. So like I said, unfortunately, I don't have time to get into all of them, but I'll just read down through them here quickly. Attribution, right? Regardless of what model you're in, attribution. Who is in this model? As simple as it sounds, can be very, very difficult. Really understanding who is in the model you're performing against the contract is absolutely critical. Risk adjustment and stratification probably speak for themselves. Care management and coordination, and this is the one where we're seeing the most uptick, the most focus on, hey, I'm in value-based care arrangements and my success is going to be determined by, and where everybody's really focusing time and energy right now is care management and care coordination, which isn't surprising. We all know it works. It just hasn't been funded in the past to the extent that it will be now with value-based care. Patient engagement, closing care gaps and improving quality, and then ultimately, cost and utilization. So back to the old, this is a budget, right? If I have a $100 target, I need to be tracking throughout the year and understand, am I at $90 in December and I got some shared savings coming my way? Or am I at $110 in December and I'm going to have to write a check to somebody unless I do something, right? So that gets really important to manage that throughout time as it goes. So we took that, we created a little assessment around it so that people can take it and say, hey, generally, where do I stand? And we did a 3-tier, right? But it based on our experience as if you do these things well, you're well positioned, or if not, et cetera. And then we also developed a checklist so that people have something they can take back physically into their organization and mark it up, work with people, take it to management and say, hey, we got this, but this line item we haven't thought of, but they're right, we need to deal with it. So that's how we're trying to enable our clients. And then we do a lot of strategic and tactical planning with them as well around those 6 essential elements.
Right. Okay. Sounds good. Would you mind sharing an example, perhaps a successful case study that you have seen, like a successful example of a company implementing value-based care successfully? Maybe it's one of your customers at Azara. Yeah,
we have a number of clients. So we had a number of clients recently go into MSSP, so Medicare Shared Savings Program. That's their big ACO program, and their newest ACO program, ACO Reach. And it's been interesting to see the differences between the two. But by taking the elements, and not all of them, part of what we talk about is you don't have to be top performing on each of these 6 elements, right? And you don't got to do them in order, but if you want to focus on things that are going to get you there, this is how you do it. So we had a client that entered into both of those types of contracts, MSSP and ACO Reach, and they focused very heavily on care management and coordination using our platform. and we're able to reduce gaps. Really, gap closure becomes really critically important in success in an ACO. And our platform then could find the gaps in care, move them over to our care coordination platform, and then there are some called community health workers, others are care coordinators, navigators, whatever it may be. They could contact all of the different patients, make sure that those gaps got closed, and at the end of the year were very successful. So they implemented that process during the year, very successful. Their gap closure rate was something like a 40% improvement from what it was the previous year. So all these things can be happening. It's a lot of strategy and how are we tactically going to accomplish what we do and then execute against that plan.
All right. And what does the role of data play in this whole value-based care approach? And I know that it's absolutely critical, but maybe you can elaborate a little bit on that. And how can companies or healthcare organizations go beyond the subjectivity and the complexities that lie in data and data measurement, to really unlock the ultimate objective?
So as you said, data is core, right? So to our 6 essential elements, as you were talking about, kind of the visuals there, the underlying component is data and health equity costs. And data is, if data is not available, then you're flying blind, right? Which we know. But sometimes you can get the data, but it's not good data, right? So we work with a lot of our health plans and provider organizations in kind of matching up their data. So if one of or the other just sent their file over, it would just basically be, we have nothing in common because there's no true interoperability. Then you're spending all this time trying to wrangle data and make it trustworthy, for lack of a better word. So we sit in the middle. So one is get the data, but two, ensuring it's good, clean data, and the parameters are in place to ensure it stays that way. Then I think a challenge is really taking that data to the next level. So there's low-hanging fruit in that data, right? Which is these care gaps, for instance. They're easy to identify. Once you get all that data normalized and figured out, we can do that. Then you start looking into more advanced with your risk stratification as an example, right? So in our system, we have multiple ways that you could do risk stratification. Our proprietary model takes into account, I believe it's over 40 different components at this point. You need data for every one of those components, right? But now I can really start to stratify my population off of things like SDOH, which is critical, off of things like mental behavioral health, off of things like chronic diseases, what their level of acute setting attendance is, so inpatient or ED. Now you carve it out, and what you want to get to ultimately is a small percentage of your most at risk and at high cost patients so that you can put them into care management. So really having the ability to get the data, clean data, and then use it in a sophisticated way. And one of those sophisticated way examples is really strong risk stratification.
And what are some of the KPIs that, when I think about value-based care, I think there's like at least two stakeholders, right? You have the payer, right? The payer, and I imagine that it could be both government insurance or private insurance. Mm-hmm. And then you have a health system or a healthcare provider, right? So you have those stakeholders. And, if you want to transition from fee for service to value-based care, it's because you're trying to maximize health outcomes. You want to lower costs. And then by doing that, it's kind of a joint program to achieve those metrics. What are some of the KPIs that Azara would recommend for consistent and objective measurement across this? And I know that you already mentioned that it depends on the contract, and each contract is going to be different. So I understand that, but I think about you want to improve health outcomes. Therefore, the question is, what health outcomes are you trying to measure? You're trying to reduce costs.
Right.
but also so on the one hand, it's like, what are some of the most common KPIs that you guys would recommend? And on the other hand is, where can this go wrong in terms of incentives? Because sometimes the incentives are good for one stakeholder, maybe the payer, but there might not be for the provider. So,
right. Well, I'll give you an answer. You may not love it, though. I'll just warn you now. You mentioned early on that this really should be a collaborative when we get to value-based care, right? So fee for service, you take payers or health plans and providers, and essentially nobody liked this term mortal enemies, right? It's a two opposing forces with opposing incentives, et cetera, et cetera. So that's decades and decades of put into place. We did a market survey not long ago, and the trust between providers and payers is extremely low, like extremely low. And now what we're saying is, hey guys, to be successful in value-based care, you need to be partners. Well, that would be like taking, the guy you were fighting across the street in your neighborhood for 40 years and now all of a sudden saying, hey, let's be best friends. It's not something that happens easily, right? So part of this from a metrics or KPI perspective, and I raise this, is they need to be jointly developed. That is the key, 100%. Joint development with their payer partners or health plan partners, because if not, nobody's going to be happy at the end of the day, even if you hit your metrics. So I truly don't believe there are standard metrics at this point, right? I think you're going to want to participate in the different arrangements. You're going to have internal metrics too, right? Because not everything's going to be based off of contracts, right? The clinical staff's going to have their own goals and everything. So we have usually a mix of internal KPIs and then contract-based KPIs. One of the keys is that health plans and providers have to start working together and understanding this now is mutually beneficial, whereas our previous world wasn't. We were opposed. There was one bucket of money and we were both trying to get the most out of that money, and rightfully so, right? That's how it works, not blaming anybody. But now they got to partner up to get as much of that money as possible. And that's where I would say you want to set KPIs, because if you don't have a clear line of sight to what both the health plan and the provider are incentivizing, to your point, those incentives can get really out of whack. From a bigger picture, that isn't always a concern with value-based care as well. Aren't they going to be screwed up incentives? So for instance, I want to reduce admissions per 1,000 by 10, let's say, right? Somebody could say, well, that's arbitrary. What if those 10 people need to be admitted and you're just not going to admit them because you're trying to hit your KPI, right? It's a very simplistic model, but expand that, it makes sense. So that is always a back and forth. So then you start to try to balance that with clinical outcome measures to say, okay, well, you cut 10 people out to save money, but you actually ruined yourself on your other measures. So there's this constant trying to balance measures out. What I think ultimately we're going to see more and more of is capitated models, partially capitated models, right? So you got 10 people, you got $100 for the year. I'm not asking any questions. I'm not looking for reports. I'm not monitoring. You come in under that, you get the difference. You come in over that, you got to write me a check, right? It just simplifies so much of this reporting burden and everything else. Now you shift some of that concern to the provider organization. Say, okay, well, now who's watching them, right? So there's always challenges to any one of these, and that's why they're changing every year. Hopefully it ends at some point, but right now it's a never-ending evolution of tweaking and changing, and somebody comes up with a brilliant new idea, and it just keeps going.
It's still evolving for sure.
It's evolving for sure.
And also, when you talked about capitation, I think the other key element to consider is benchmarking. To do capitation well, is like, how much are you supposed to provide for X procedure or for this therapeutic category or whatever. You need to be able to have benchmarks that everyone can trust, and that adds another layer of complexity.
Absolutely. I was just at the NACOS, which is the National Association of ACOs conference last week, and that is an ongoing, always conversation. They were talking to CMS leadership about it. That's another one where there'll never be agreement, right? I'm always going to want that to be a little higher. They're going to want it to be a little lower. But the way the methodology is right now, it keeps cranking down. So if you improve year over year, which is what you would want, it gets harder and harder for you to see any incentives because you're being judged against your own improvement. So after 3 years, people are saying, why am I in this program? I have no chance to make any money because the benchmarks are impossible. And for their new ACO REACH program, they're having benchmarking issues that are making it challenging. So I'm glad you brought up benchmarking. That is a hot button topic for sure.
It's a hot topic for sure. And can you talk a little bit about ACOs? Like what is I know it's accountable health organizations. What does that mean? And can anybody be an ACO or explain a little bit for the audience?
So the most popular and successful ACOs have been through CMS for Medicare. Predominantly, so the number one ACO model in the country is Medicare Shared Savings Program. And that there's a couple different ways you can set that up. They have different tracks, so you can take on more or less risk, etc. But you set up a legal organization. You have an ACO, you have an ACO board, and then you have members of the ACO. And usually that's going to be a mix of hospitals and primary care, some specialists, but primary care especially. And again, that focus on the ACO is keep people out of the hospital, consume primary care, care coordination, all those sorts of things. And then what CMS says is you have 50,000 Medicare beneficiaries in your ACO. Here's your benchmark. Here are your quality metrics, which this year there's 3. There'll be 5 next year. And then if you can care for that population underneath the benchmark, you see savings, you get a check. And if you go over that benchmark, it depends on what track you're in, because some tracks are no risk, right? But other tracks are higher risk, so higher risk, higher reward type of concept. They're all that basic concept. There are Medicaid ACOs at state levels. There are some commercial ACOs. But at the end of the day, we started just talking about networks, because an ACO, an integrated care delivery network, clinically integrated network, they're all essentially the same thing, right? They're a group of people that are not owned by the same company, generally. So independent providers and things like that, getting together to take on contracts, generally is what it is.
Okay. Thanks for explaining that. All right, let me shift gears a little bit. And I would love to talk, discuss some of the growth challenges of Azara Healthcare as a company. And in this podcast, we talk a lot about how to grow and scale companies,
right,
and share the lessons. So, one of the questions that I wanted to ask you is what are some of the unique challenges Azara has faced while scaling as a company? Every company faces, growing pains.
Yep.
We all know that, and at different stages of the company's life. But what has been unique to Azara? What are some of the challenges that you have been facing, and maybe you can share some of the things that you've done to continue growing.
One of our interesting challenges, I don't know the biggest, but interesting challenges was, so when I joined the company 4 years ago, Azara Healthcare was a single line of business with federally qualified health center, right? So selling population health and value-based care software to the underserved provider market. When I joined, we expanded into the commercial market. Now, on paper, it's doctors providing care that need population health, doctors providing care that need population health. Reality is you go a little bit layer into those two markets. They are very, very different markets. How they purchase is different. How they sell it or how they buy is different. The expectations they have are different. The type of salespeople they want to interact with is different. And it took a little bit longer to figure that out, I think. So if I was going back and I was going into a new market, I'd do a real heavy nuts and bolts on what is different between the two, because we looked at them a little bit surface level and said, hey, these really aren't that different. They're for profit. These guys aren't. But other than that, in reality, it's servicing two very different markets. That's one challenge. So if you're going to, as you grow and scale, often you're not just going to keep going vertically, right? You start going horizontally with some new products or going to some new markets. I think that's a critical component as you're looking at that, is truly understand the buyer in each of those markets, and they may not be as similar as you think. And you can save yourself time and opportunities.
Let me double click on that.
Yeah.
What were some of the key differences between those two? Because at the end of the day, you just said that both of them are providers,
right,
targeting different populations. But at the end of the day, they are providers. So what were some of the
business
key differences?
Business model. So in the federally qualified health center, it's not for profit, and the way that they get funding is through grant money and through government funding. And then they also get essentially a prospective fee service, but it's essentially fee for service payments. But they don't have anybody saying, did we make a profit this year? What is our margin? What's the income? How much did you spend on X, Y, or Z, right? And we, the vendor in that market, our position in that market is where we have about 45% of the market. So we're the market leader. And when the market leader walks into a door, right, you get a different level of engagement. Well, in the other market, we were nobody. We had no brand recognition, and they're for profit. So the people making decisions over there are potentially putting part of their career on the line if they spend $500 to $1 million on a solution that doesn't work, right? Their view is very different. They want to talk ROI. What's the ROI on this? How am I going to get this? And they tend to be more sophisticated and have higher expectations. So when you look at those, how you approach those two markets, now that you understand that underlying component, it's very different than assuming, hey, they're the same because they're both provider organizations.
Okay. And what's an example of how you adapted the model, or whether it's the go-to-market approach or
we did a lot more marketing to get out there, right? Because we had to build brand recognition from the beginning, which we've been very successful at. But approaching from a sales perspective, understanding that everything you pitch has to have not exactly, but has to have a clinical component to it, and how's this going to make us successful in value-based care or these other arrangements components to it, right? The ROI, we did a lot of ROI work. So we didn't have to do that being the market leader in the other line of business. But in the new space, so we went back into our database and started saying, okay, let's think of use cases. Let's think of different case studies, success stories, things where we can show our software and technology move the needle in meaningful ways that we can then use those as proof points with our prospects on the commercial side. So it became a lot more about selling value and delivering proof points that we generally don't have to do on the other side, because everybody knows we are valuable when you're the market leader. And the company's just done an amazing job, and our leaders have done an amazing job of building a brand reputation in that space that is amazing. I've never been in a company that had that advantage, and it is very nice. Very nice.
Sounds amazing. Yep.
It is.
The other potential issue that a growing company can face, it's kind of balancing agility, being flexible, launching new products, and growing fast, with being structured, being disciplined, having processes and scale, implementing processes. So how has Azara been able to balance, the flexibility, agility with structure? Can you talk a little bit about how you have been able to do that?
And I wish I had a silver bullet answer for you on this one, but I think it all depends when, where, who, what, right? It's all so individualized. What we did was really in that growth stage have to go from everything can be literally known by an executive to all of a sudden that's just not possible, right? We're too big. And the executives can't know everything about everything all at once. That was a big learning curve. Building out the middle layer of management is something that nobody should underestimate. So our organization, we had executives, and then we had kind of everybody doing work, right? And in smaller companies, that's not unusual. As we've grown, we've needed to build out a layer of managers, and we didn't have that internally, right? As you know, good managers aren't always just the best at what they're doing and you promote them. And a lot of times, especially in the technical space, they don't want to be managers or people leaders. So building that out and understanding that that's not just, hey, let's do this. We'll hire 6 months from now. We have an effective management layer. That takes time. You got to do all that. Then you got to get people in. Then you got to understand how to operate with a management layer, right? And if you're only used to small companies, you may never have had a middle management layer. And it gets very uncomfortable when you as a leader don't know everything. That took time for people to adjust to. And all these things take time, right? So that's important. From a process perspective, I think there's no way to scale without putting process in place. Process is a bad word, especially for anybody coming out of a startup and moving into growth stage, right? That group of people generally do not like process. So explaining, I love transparency of, hey, okay, we don't love the process, but here's why we have to do the process. You may never like it, but at least I've explained to you the business reason we need to do this. And then you need to hold people accountable to the process, or else it just falls apart right away, right? The other thing is transparency around, this sounds dumb, but building process is a process. Your V1 process is never the end all be all, right? You learn. So now people are like, oh, well, this doesn't work. We did a process. We're already changing it. Yeah, that's how process works. It evolves. It gets better. It gets more nimble and refined as we go so that we don't have any extra burden. But then ultimately, I think the real key is strong leadership that can say, in this case, we're either not doing process or we're skipping process because there's a good reason for it. We're going to be agile. Because we don't want to lose our ability to be agile, right? That's one of our main competitive advantages against the big guys, is we can move quickly and be agile. And that just really is a leadership methodology, kind of a mindset where everybody realizes it's going to be gray, right? Where some people want, this will be process, this won't be. And in reality, that'll never be the case. But as you grow, that process is going to grow with you. And as an early stage person, sometimes that's not easy to accept.
Yeah.
But it pays off because you can't manage large groups of people without process, unfortunately.
Yeah. And you have to stay flexible and, adjust as you go along. For sure. Then I have one final question before we wrap up today.
Sure.
And what advice would you offer to any emerging health tech company about the strategic implications of balancing technological innovation and the practical needs of your existing customers? And what I mean by that is, on the one hand, as you grow as a company, you're always thinking about, I need to innovate, I need to launch new products, I need to be at the top of my game, and that creates that requires a lot of attention and resources internally to focus people's attention and work on creating newer products, launching newer products. But when you do that, then you often forget about your existing customers or your existing flagship product.
Right.
But you need both. At the end of the day, if you want to keep on growing, you need to delight your customers with your existing product, but then you also want to build and keep innovating. But it's hard to do both. From a strategy point of view, like, what advice would you offer in terms of balancing those two?
The first I would say is just, it should be a constant running conversation, right? It is with us. It's existing client base versus net new features for future clients, right? In the commercial side or wherever else. Our CEO, Jeff Brandeis, has done an excellent job of making sure we don't lose focus on our core customers, right? I shouldn't say core customers, our customer base, and say, okay, hey, there might be some new shiny objects out there, but don't forget, we got here based on this set of customers, and we're not going to leave them in a lurch. And we need to make sure we don't stop innovating for them, right? And move other ways. So that balance, I would say, first and foremost, don't forget your client base, your original client base, or else before you know it, they'll be gone and you have two of your net new clients and it ain't going to work out, right? And I've seen that a lot of times. And it's easy to do. It's exciting, right? New, it's exciting. These guys, our clients are happy. And I've heard that before. Our clients are happy, no worries. Well, they can become very unhappy very quickly, right? It doesn't take years for a client to become unhappy. It can happen at any moment. So focus there, but it really is that constant conversation. I think, should we do this? Should we not? Pros, cons, and getting that leadership together. And that strong executive team makes a difference a lot in that space, right? You want to get all those minds kind of thinking about where to go and what to do. But big fan of can't forget that your original client base concept. And Jeff has been great with that.
Great, thank you. All right, Matt, thank you so much for your time today, Matt. I really enjoyed our conversation. Thank you so much for sharing your experience and your wisdom. And also thanks to everyone who is watching and listening to this episode. Thank you so much. And until the next time.
Thank you so much for the opportunity. I appreciate it. I enjoyed it.
Thank you, Matt.
Bye.
Bye.